Thank you for nice words, David. So I'm going to present the novel therapeutic approaches in metastasis, from mechanism to transplantation. So I will share with you some of my background. I did first nursing starting 2004 till 2008. After that, I did 2 master degrees in Greece. So Master of Medicinal Chemistry and Biochemistry, and started in parallel my medical school. And also, after having the first master, I started my PhD in biomedical sciences. 2015, end of 2015, I moved to Germany at the University Medical Center Hamburg-Eppendorf, where I started my postdoc for 4 years there. So also some time to learn better German. So my level was not good in order to go to clinics and talk to patients. So during this postdoc time, I got a training in Yale University for performing some experiments with mice and parabiosis, and also in Pittsburgh University to learn the orthotopic liver transplantation in mice under supervision of Professor Thompson there. Then I did my residency 6 years. In 4.5 years of residency, I applied for the STS fellowship. I was really happy about this position, and I started my fellowship almost 1 year ago. So it's like missing 2 months to have the full year. I have applied now for habilitation. This is a title in Germany before professorship, and my next plans after the STS fellowship is to do an HPB robotic fellowship and a pediatric liver transplantation fellowship to be able to operate also children. During all this time, so I had published a plethora of publications with a lot of very important funding for me. So the last years. So without this funding, will not be anything of these publications possible. And my next steps is to apply for ERC starting grant. This is a European grant. That is the next step, and also a professorship that is sponsored by Else Kruner Frisenius Stiftung. So my research team are 12 members, are very hardworking and very talented. So I have 2 postdocs. Hermias will also join us here, having David to help me to bring him here. So he's a veterinarian microsurgeon, but he is able to do kidney and intestinal transplantation in rats. Then I have 5 PhD students, Dr. Zhang, Dr. Xia, Dr. Papazoglou, Dr. Song, and Dr. Stampolitis, and 3 clinician scientists. So during residency, we have the possibility to do 1 year or 2 years in parallel research together with our residency, and a technician, Tom Blankenburg, that he's always there for us. So I'm going to share with you some information about metastasis that I'm sure that you all know. So metastasis is the leading cause of colorectal related deaths. 30 to 50% of patients that when they diagnosed with colorectal cancer, they have in parallel liver metastasis. And metastasis is a multi-step process. So we have 4 steps: invasion, intravasation, circulation, extravasation, and colonization. And always we have to take into consideration the CRC. The colorectal cells have a crosstalk with stromal and immune cells during this progress. So I will give you an overview of some of the projects that we have ongoing in my lab. So we have a cohort of melanoma patients that they have liver or other type of metastasis. And during the cycles of immunotherapy with checkpoint inhibitors, we check the levels of different cytokines. So this was done with O-link technology, and we checked around 48 cytokines. And we found the only cytokine that was elevated after cycle 1 was IL-10. And then we check if the patients, they have high levels or low levels of IL-10, if they are responders or non-responders. And you can see that the patients that they have high levels of IL-10, we have more responders compared to the group with the low levels of IL-10. This is a project that is the PhD of Dr. Zhang and is at the moment ongoing. We are going to submit his publication in the next year. So then we have another project on that is my main funding at the moment. This is a clinician scientist program that is focusing on finding how the microbiome affects the liver metastasis formation. So we have tried different floras of for microbiome, and as you can see, we have with dysbiotic floras, these three ones here, we have more metastasis compared to the normal flora. Let's say that this is a clean flora that we have in Hamburg, and we send 16S sequencing from livers and from the colons, and as you can see, we have different consistency of microbiome in liver and in colon. Doesn't mean that everything that is in colon is also in liver. So some of the pathogens, they cannot survive in the liver. So this is an ongoing project that we are now going to do germ-free mice. We are going to do different checking this bulkoduria that we found in mice with liver metastasis in germ-free mice if has a rescue of the phenotype, and it's really interesting to see if the germ-free mice develop metastasis. Then we have a model to deplete gamma delta T cells. So we inject the mice intrasplenically cancer cells, and after giving diphtheria toxin, we can deplete the gamma delta T cells. And as you can see here, mice that they have lacking gamma delta T cells, they have more metastasis compared to mice that they had gamma delta T cells. Another project that we do in collaboration with Suen and with Tao is checking the sex specificity in liver metastasis. So we found that the male mice, after intrasplenic injection of MC38 cells, develop more metastasis compared to the females. And then when we give to these castrated mice, develop less metastasis, so they behave exactly like the females. And when we give them testosterone supplementation, we have rescue of metastasis. So the mice, they go back to the male background phenotype. And at the bottom, we did the same experiment using females and giving testosterone to them. And as you can see also, we have a difference in metastasis formation. So this is a project that is now under review in immunity. Then in collaboration with Professor Friese and Dr. Zilau, we check the role of olfactory receptors in lung metastasis. So olfactory receptors commonly are expressed in our smelling device, but it seems that after injection of cancer cells, the endothelial cells upregulate these olfactory receptors. This we did with a ribosomal RNA technology that you don't need to sort the cells. The cells are GFP positive marked, and you can isolate the RNA from them and send for bulk sequencing. And we found olfactory receptor genes that are upregulated. So this is an ongoing project that now we use CRISPR-Cas9 mice to silence these olfactory receptors induced in mice lung metastasis and check if this has a functional impact on lung metastasis. Another big part of our project is studying the role of tissue-resident immune cells, that these are cells that are there in order to attack different pathogens or cancer cells, are the first cells that the cancer cells found when they go into the liver parenchyma. And at the moment, we have a project that we isolated during extravasation step of liver metastasis. So after 12 hours of cancer cell injections, we isolated these cells and we did single cell sequencing. And as you can see, we have different types of immune cells. And these different types of immune cells, we checked IL-4 because it was upregulated in the whole immune cells. And we found that the main cells that express IL-4 are the CD4 NK T cells, and the main responders of IL-4 signaling are the macrophages and CD8 T cells. And then in order to, so this is a project that I'm going to submit for the ERC starting grant. And in order to check if this is true. So now is coming the orthotopic liver transplantation model in mice. So we use this model, except of using parabiosis that is not allowed to use in Germany. So I did these experiments only in Yale that is allowed to use the parabiosis model, means stitch two mice together that they serve the circulation. So in this model, you transplant a liver that has CD45.1 immune cells in a CD45.2 recipient. So means you can distinguish which cells are coming from the liver, and they are the tissue-resident immune cells of the liver, compared to the circulating cells. So this is the preparation in video here of the suprahepatic vena cava with 10-0 sutures. And this is the procedure that we do into the recipient. So we explant the liver. It's exactly the same procedure that we do for humans. This is under sterile microscope. The majority of the anastomosis is 41 times magnifications. For the vessels, for the suprahepatic vein anastomosis with 10-0, we use like this one. I use like 25 times magnification. And this is the most critical part of the operation. So it means if you have a hole in this suprahepatic vena cava anastomosis, mouse is not surviving after 3 hours of operation. And yeah. So then we use the cuff technique for the portal anastomosis, and here is the time of reperfusion of the liver. So we remove the suprahepatic vena cava clamp, and then we perform the cava anastomosis with the same technique. So using a cuff from donor to recipient and do just a ligation with 7-0 silk. And what is this? So this is, I think, the first time that will be published soon using this model for studying the tissue-resident immune cells. So the idea is when you have the CD45.1 immune cells and the CD45.2 that are coming from circulation, you can sort these cells, you can send for bulk sequencing. And as you can see here in bulk sequencing, we found that tissue-resident cells, 12 hours post-cancer cell injection, they have highest expression of IL-4. So this means that what we found in single-cell sequencing is true, and this means that we now can continue with IL-4 signaling, so silencing the IL-4 signaling on CD8s, on macrophages, and check if this has an impact on metastasis. So my vision for and my ongoing projects are chemokine and related projects, lymph nodes and metastasis. So we have a model that we check with ICG camera the lymph nodes that are infiltrated with cancer cells. Project on microbiome pathogens and metastasis, cytokine and tissue-resident immune cells, checkpoint inhibitors in metastasis, sex differences in metastasis, gamma delta T cells in metastasis, and different cytokines like IL-17A, IL-17F in metastasis. The aim is to understand the mechanisms, develop new strategies, and go into clinical trials for doing a therapy for patients with colorectal liver metastasis. So all this starts, I think, also the idea of orthotopic liver transplantation and tissue residency because of my interest on microsurgery and on microsurgical models. So we are able now to perform in my lab liver transplantation, tracheal lung transplantation, kidney transplantation, small intestine transplantation, sleeve gastrectomy. We have a project with pregnancy and so bariatric surgery, spontaneous and forced liver metastasis, colon anastomosis, rectum resection, and mouse simulation models. So these are 3D printed instruments that I said from Dr. Roldani that it was 2012 when I started doing microsurgery, my idol. So and it came the time to meet him here, so it is impressive. So I'm always happy about that. And before coming here, so some years ago, he was sharing with me his files to print these organs. And this is the set of microsurgical instruments that we use. It's everything for 10-0, 9-0. And this is a stereo microscope that is ongoing. So and we can operate and doing all these models. This is a stereo microscope that is with a different kind of magnifications, and always we use foot pedal in order not touching everything, so in order to be sterile. So my surgical interest and teaching is HPV procedure, kidney and liver transplantation, pediatric organ transplantation, simulation models for organ transplantation, and robotic and laparoscopic surgery and simulation. So I had the idea to apply for a grant in 2019 during the COVID period because of a lot of reduction in our elective cases. So as residents, we were not able to operate elective cases, and specifically for the residents that they were the first 3 years. So then I wrote this grant, and we are able now to have a simulation unit from Symbionics with a robotic simulator and 2 laparoscopic simulators. So if you guys like to go for some training there, I can arrange and you can join this unit. So means you can do prostatectomy. It's the best that exists in this robotic simulator. So the graphics are amazing because they have used so many videos from different urological case prostatectomies that it's like you operate in a real human. And laparoscopic simulations that always you have also the feeling like it's during the laparoscopy. And so as a resident in Germany, sometimes it's not like you guys that I have seen like first year, second year, third year residents for doing a kidney transplantation and doing anastomosis. So we were not allowed to do anything on transplantation. So for this reason, I was trying to establish some simulation models in order to practice and improve my skills. So these are all models with latex and different kind of materials that I can practice, for example, bile duct anastomosis and pancreatic jejunostomy, vessel anastomosis. And this was the current publication that I did also during the time that I was here with having a simulation model of orthotopic liver transplantation. And my vision is to, at the moment, I'm creating a new microsurgical lab that will have a CT scan for mice, an ultrasound, an ICG camera, a Doppler for mice. And I'm planning with Microsur to have a microsurgical robotic system. Means you are operating from a console like the Da Vinci one, and you have the robot with that you can apply also different kind of instruments on that. It's not with their own instruments, and you can perform what you perform as under microscope with your hands, but with not a lot of tremor. And here I would like to show you this publication that we just did with trying to have a model that my opinion is always it's good to start from this model, so you cannot go directly to a mouse if you have never used a microscope, if you have never used a 10-0 suture, because I mean you can easily break these sutures. So if you have never used microsurgical forceps, so the idea of this came after buying the CT. So after having a CT for mice, you can really easily print organs. So we make some scaffolds to print a liver for mouse. Dr. Proixas, a very talented surgeon in our department, had the idea to create. So the idea actually came from, he told me why we don't use condoms to make a vessel anastomosis, and then came the idea of latex and doing some vessels, some bile ducts, some small dimension vessels. And the idea is like back table here. You prepare first with the cuff technique. The cuff is coming from a 22G catheter that we are cutting under the microscope. We use also a stent for the bile duct. So this you can see now the small tremor under stereo microscope, 41 times magnification. That in theory, when we have the robotic system, you will not have any tremor there. And this is the cava, inferior cava, again with preparing with the cuff technique. And now starts, so we were cleaning not all the organs, but cleaning only to create the skeleton to create the mouse, and here is the suprahepatic cave anastomosis with 10-0 suture and under 25 times magnification. So the speed is 4 times faster than reality. Unfortunately, it's not so fast. And after finishing the suprahepatic cava, we go and we perform the same. So these are the instruments that I said from Dr. Aldani. So you can, I mean, the idea is very smart. So you can fixate the vessel of the recipient in order to have a stable vessel and introduce the cuff of the donor. And then after introducing the cuff of the donor, we just ligate with 7-0 silk. And let's go now to, so in the bile duct, it's, yeah. So in this, it's a little bit bigger than the reality. It's not so easy at the reality to introduce so easily, but because we use scaffolds, these catheters, then it's easy also to introduce the same catheter. And at the end, you have this model that I sent it to 10 centers in 10 microsurgeons in the whole world that they are able to perform liver transplantation in mice. They evaluate the model with a questionnaire, and then they send me the results, and we published. That is an important and nice model to have before starting doing in vivo orthotopic liver transplantation. So now, coming to the part that I'm also lucky that I have support of Dr. Harriman to establish also here microsurgical models, and especially the kidney transplantation in rats. So this is a kidney transplantation in rats that we are going to establish here and checking the impact of urobiome on tissue resident cells, as we discussed before for liver. And the procedure is exactly like in humans. So we isolate the kidney. This is the aorta of the rat. This is the cava, the vein of kidney. And then we go to the donor. We coagulate the lumbar vessels. And then we clamp whole aorta and whole cava. So this is easier to do in rats compared to mice. And the next step is to go to mice. The mice, I have tried to do some, but the problem is sometimes you have stenosis of the artery. And to be honest, for microsurgery, I prefer rats because it's real vessels, it's everything real. So you can do also a small mistake and the rat will survive. But in mice, if you do a small mistake, the mouse will die. So it means in a 3-hour operation, you have to be 100% focused to not doing any mistake. And then we use 9-0 to do the anastomosis. Is a little bit different than what we do in humans because you don't have anyone to help you keep the hold the suture for you. So we have found a little bit modified method in order to be able to do yourself. And under stereo microscopes, we commonly cut a very short suture that we don't have all the time the problem that the suture is coming in front of our view. And now we go to the aorta and the artery anastomosis, and it's the same idea like we do in humans. Finalizing the arterial anastomosis. And this is the nicest time for every transplant surgeon, the reperfusion. And then we check that the artery, so you can see here that we have some spots that they are a little bit darker than commonly. So in theory, this kidney is recovering also like in humans. The good thing with rats and mice is that you don't have ischemia, a lot of ischemia reperfusion time. Maximum you have like 40 minutes. And here is a ureter anastomosis. Now I'm doing a ureter with bladder. So because sometimes this is stenotic and it's not working well. And then as a last, I would like to share with you the laparoscopic appendectomy. So means having the possibility to do an operation in simulation. and how this is working. So you have all the structures like in reality. You have the possibility to choose your instrument, and after choosing a Maryland, you are always doing the window there. So you have always to find the structures like the artery there and clip it, and then do the appendectomy. And the feeling is almost the same. So at the moment, I'm doing also a project with simulations, with simulators. So because a lot of times we have now the possibility to check the brain reactions during the operation, if we have a bleeding, if the brain is reacting differently, if the person is experienced or non-experienced. Appendectomies commonly they do people that are first, second, third year of their career, and I'm now doing a project like collecting very passionate students that they like to use the laparoscopic simulator and check with EEG their brain reaction after bleeding. So you can cause with a tablet spontaneous bleeding on the artery during the operation, so you don't inform the surgeon before that. And we are now collecting, for example, you can check their sex differences. So if females that I'm thinking they're behaving faster and easier than male, for example, so we have to see if this is the case. And so this is the model that someone can use. The procedure it takes for an experienced, so for a student takes like almost a normal appendectomy, 30 minutes. But for someone that has done the real ones, takes like 5 to 15 minutes. Depends, because they have also modules that you have with more inflammation, with abscess, with different difficult level. So as we do the clipping of artery, and of course you get a score after that. So you need to operate like it's a real appendectomy, not like, because you can do also in 2 seconds, but your scoring, or in 1 minute, but your scoring will not be good as should be. So this is the idea behind. And now we use the loop in order to do the appendectomy, and at the end cut. And we can also wash and do some suction. So the ongoing projects in my lab are, as I discussed before, related to CD8s and checkpoint inhibitor therapy, microbiome in metastasis. We have now a micro CT that we try to make an algorithm and quantify the lung and the liver metastasis. A project related to KRAS and CCL22 IL4 pathway, a project on IL-17 and colorectal liver metastasis, on VOX and olfactory receptors, and then the differences in local immunity for different organs. So because we found that the macrophages in lung metastasis with macrophages in liver metastasis, they behave not the same. So we have to find which is the difference and if it's the microenvironment or the other immune cells next to them that plays a role. So we have also transplantation related models with lung transplantation, with liver transplantation, and a project with using, establishing now using the liver of mother or father from a rat or mouse and transplant to kids and check if this has a better outcome. Projects with simulators and artificial intelligence for vessels. So even you can do a vessel anastomosis and do a video of that and try to analyze with artificial intelligence, and then check with MRI if there is a leak or if there is a stenosis. We have a project on pregnancy and bariatric surgery and the outcome on pregnancy, and also simulation models for the different organs. So now I'm going to publish on lung, and then will be the next on kidney transplantation. So my visions for the coming years is to have personalized therapeutic strategies for patients with liver metastasis, using liver transplantation as a cure for metastasis after knowing the immunological background behind that, doing some clinical trials with the transplantation for patients with non-resectable liver metastasis. So if you go to all bibliography, you will find only clinical trials with patients with liver metastasis. Is nothing published about functional experiments in mice. And I was wondering why, and discussing this with Professor Thompson in Pittsburgh. And I think the reason is simple. So because there are 10 people in the world that they can do liver transplantation in mice, so means these 10 people have to do also studies with liver transplantation. So for this reason, doesn't exist anything published there. And whatever we have as studies are all everything directly on clinical trials in humans. Then doing with transplantation studies on immunological tolerance, rejection outcome, and models for liver, kidney, and lung transplantation and simulation. So, of course, I would like to thank all of my mentors, starting from my PhD mentor, so Professor Huber, that he's my mentor for postdoc and the guy that really helped me to establish my own lab there. So he's very talented and really supportive, and always giving space to people to grow. So this is always that you like to have a mentor like him. So my directors at the surgical department, Professor Hackett and Professor Itzpicki, the director, Professor Althafer, that I did my 6 months HPB part of residency there. So he's one of the most talented surgeons that exist in Germany for HPB. Dr. Thompson, Professor Thompson, and Professor Flavel for my training in Yale University and in Pittsburgh University, and of course my other collaborators. So in La Paz Hospital, Professor Hernandez, that he's performing pediatric liver transplantations. Dr. Lee, that he's now director of in Beijing for the transplant unit. He was back home in Hamburg, so he was assisting me in my first cave anastomosis, so I will never forget him. And so Jung Meyer, that showed me the lung transplantation in mice in Switzerland. Professor Cobalt and Professor Gondolesi, that showed me the intestinal and kidney transplantation in mice. We recently started collaboration with Professor Sabizokhin and Dr. Blezinski about clinical trials for patients with colorectal liver metastasis. All the HPB team, Dr. Segeti, Dr. Oldani, Dr. Salkeplan, and Dr. Kim, that this 1 year was very supportive with me, and I really enjoyed the time here. So I'm happy that I found good people and people that really support and improve my surgical skills. And of course, the talented transplant surgeons for kidney, Dr. Guan and Dr. Harman, that always are there for me. And I was not able to do any kidney transplantation before coming here. And I'm at the level now to be able to perform in a good level some of the procedures. So I'm happy about that and happy to have all of you guys here. And of course, all the funding that all these years supporting all this research. So without them will not be possible. Yeah, I would like to thank you for your attention. Happy to ask if you have questions and all. So if someone has interest to do a PhD or some research back in Hamburg, he's welcome to come.